IFARA welcomes our viewers to this series of programs covering the retrovirus conference held recently in Boston. We believe this program covering science, policy, and behavioral issues should be interesting to all viewers in the Portland and Vancouver areas, and especially informative to local medical and non-medical providers in the field of HIV and AIDS and hepatitis. Welcome to this program on World Health Organization. We're here at the CROI in Boston, and we're here with Meg Doherty, who's from the Hepatitis and HIV Department at the World Health Organization. We really appreciate her taking the time to speak and give a little bit of an update on the successes of the World Health Organization this year.
Okay, well, thank you very much. And from the vision of the WHO, I think it's really important that this year has been a very important year for HIV in particular. We have reached the 15 million by 2015, so we already now know that we have nearly 16 million people on therapy. But also in October of this year, we put out new guidelines to say that we are now moving to treat all people. So all people living with HIV are now eligible for treatment. So that means we have quite a bit of work to do to try to get the other 21 million or so people on therapy to reach the total number of 37 million people who will be eligible and needing treatment in the near future. So with that, in December, we put out a set of new guidelines, and here it's what we call the Consolidated Guidelines on the Use of Antiretroviral Drugs for Treating and Preventing HIV. And in here, we make recommendations around new drugs, as well as moving to treat all, as well as new prevention approaches, including using PrEP or pre-exposure prophylaxis for preventing HIV among those people who are particularly at high risk of HIV. So we're excited that we've been able to put out these guidelines, and now we're working with all of our countries and member states and regions to start rolling these out and helping countries to implement. I think we believe some of the biggest challenges are going to be around implementing the new guidelines, and with that we also have put together a whole series of recommendations on how better to deliver service, the sort of how. And we have what we call in our new guidelines a set of what we call service delivery recommendations, and I'll just plug that as well. And we're developing work around what we call differentiated care. So as we grow in numbers of people who are going to need to be on treatment, not one size fits all. And in the previous vision of WHO, we really had a public health approach where perhaps one size was going to fit all. But now we know that there are people who've been on therapy for many, many years, and they may need to only see a clinician every 6 months or pick up their antiretroviral drugs every 3 to 6 months, as opposed to coming into clinic every month. So that's another challenge that we're going to have in the coming years of how to improve care for the sickest, as well as improve both the situation for persons who are doing well on antiretroviral therapy so that they continue to get that perhaps in the community and maintain adherence and not develop resistance. At this meeting, we also are starting to look at, again, our HIV drug resistance portfolio. As more people are on therapy, we know that inevitably HIV drug resistance will start to climb. And at this CROI meeting, we had a session looking at what we're developing over the next year is a HIV drug-resistant global action plan to try to encourage surveillance of drug resistance and to know when we need to use this information to either modify the drugs we're using for second line or modify the drugs we're using for first line. So
the resistance testing you're going to be doing, will that be to determine what the best next drug would be, or will there be options? Is this something, because this is the way we operate in the United States, and obviously this is sophisticated, and it may be something that wouldn't be possible to implement.
Right. Well, it's quite different. What we recommend right now, and we believe it's still the right way to go, is doing several different approaches to surveillance, something called pre-treatment surveillance, so looking at those people who are either naive to drugs, never have had them, or people who've had some exposure, and is there any indication of a problem with resistance, either to the NNRTI drugs or the NRTI drugs. Then we also have surveillance of on treatment-resistant developing among those who are taking antiretrovirals and then fail, and with a high viral load. And right now we're looking not at an individual approach, but at surveillance, so that the country can make a decision, is there a need to change or not?
Now, you were also involved with hepatitis. This is something that is a very expensive drug in the United States.
Yeah.
I'm not sure how that plays out in the developing or the middle-income countries. It seems like the very logical and very forward-thinking approach would be to just get everyone treated. And of course, in our country, it would be extraordinarily expensive. But when you think about the fact that you would be eliminating new infections and reinfection down the line, it may make all the sense in the world if it were possible to do that and implement that kind of a program, and then still satisfy the drug company with saying, okay, this is what you need out of it, this is what you're going to get, but we want everyone treated. It's almost like a campaign for polio or something.
So it's really nice that you brought that up, because the WHO has now developed a strategy for global elimination of hepatitis C. So we have, in the coming year, we'll be getting ratified, or through what we call the World Health Assembly, a strategy, a global health sector strategy on both HIV and hepatitis. And within the hepatitis strategy, there are now targets for moving towards elimination by 2030. So reduction of new infections as well as reduction of mortality by encouraging and supporting and ensuring that the new drugs are available for hepatitis C. WHO in the past year has updated their new hepatitis C guidelines, and these include all the new drugs, and this was put out originally only a year and a half ago, and has already been updated because of the pangenotypic drugs that are coming in. And there was a really nice session yesterday here where we looked towards countries like Egypt and China and others who have negotiated quite low prices and are looking to eliminate hepatitis C as a public health problem by treating all. So yesterday, the leader of the Egyptian program showed how well they're doing and how they're moving to trying to reduce new infections, and they have an aggressive approach, and they've put on more people on therapy than any other country and combined around the world. So I think there will be some champions who are going to be looking towards reducing new hepatitis and moving towards elimination. And there was also a nice presentation yesterday by Chloe Theo looking at, okay, now we're looking at it for HIV, we have a plan for hepatitis C. Now we have to start thinking about hepatitis B, because hepatitis B elimination is also within reach. And lots of new drugs are...
It makes all the sense in the world.
Yeah.
I mean, why do we want to labor over this, torturing ourselves to treating people as they progressively are infected and reinfected, when in fact we can knock it out, as we've done in other pandemics? It makes all the sense in the world. And you just have to say, okay, from a pharmaceutical standpoint, let's just figure out who's in this. Get them compensated for their effort in a reasonable way, such as the Fair Pricing Coalition does in our country. And then make sure that everyone, say, this is the bargain. Everyone gets treated.
Well, I think that you're making a good comparison. I think in the low and middle income countries, and particularly low income countries, they've been able to have voluntary licensing with some of these new drugs and drug companies. There are the ability to bring in the generics, but I think some of the middle income countries or high income countries are really stuck because they're stuck with these high prices,
yes.
and it does.
It may seem like I can tell you the people that have to pay for it in those countries can't afford it. And I've heard this over and over again every time we do an IS meeting out of our country, and it's in a middle-income country, or when I visit there. That's the challenge. It's that the people have to themselves afford it, and it's unaffordable. They're almost like poor people in a middle-income country that are under the pressure of having to buy their own medicines, which is unaffordable.
I think with more pressure and more activism, and I think that's one of the nice things about having hepatitis and HIV in the same department. Perhaps the hepatitis civil society can really learn from the HIV civil society and start demanding the prices, and the prices come down, because I think it was a real success in the HIV field to get generic drugs and to drive those prices down to reasonable prices. And we need the same sort of movement and momentum, I think, for hepatitis C and hepatitis B. Yeah.
So what other things are the World Health Organization doing today?
So in terms of HIV, we are working on, we've launched our new set of guidelines, and now we're doing a number of, and a series of events to try to help countries implement these new guidelines. So moving to treating all, moving to develop these differentiated service care delivery models to improve the how, to improve adherence, to improve retention. We have recommendations and guidance on scaling up viral load, so a number of issues to try to address the 390s. And also in terms of testing, we're in the process of developing guidelines on self-testing and ensuring that the testing remains of high quality, and that there's, you know, when we put somebody early onto treatment, that we know they're actually infected around the world. We're also working quite extensively in prevention, and we have new guidance on PrEP, and there will be an implementation tool on how to implement PrEP, especially in low and middle income countries, and I think that is quite needed. We haven't forgotten TB. TB-HIV is one of the major killers, and we have quite a bit of work that we've done and new recommendations that have come out in our new guidelines on how to improve by a set of packages to get the sickest into care and fast track them, and to also use GeneXpert to identify infection and treat all TB patients who have HIV with antiretrovirals, so that we can reduce mortality, as well as really improving the use of what we call isoniazid prophylaxis, or IPT, which has not been as successful as we would have hoped around the world. But we have recently done some reviews that show that TB remains the #1 killer among people living with HIV around the world. And so we really do have to make headway in our TB, perhaps new drugs. WHO also held here at CROI a think tank around where is the next, what do we need next for our generation of ARV drugs? And I think we're continually looking at what could be new drugs to bring into the armamentarium of a public health approach. This year, we made recommendations to bring in the integrase inhibitors as alternative drugs for first line. And we're still looking for and hoping that the research will come out very soon on using dolutegravir in the TB-infected patient who's on a rifampin. We know that we may have to double the dose, and also in pregnant women and children. We're encouraging the companies, especially those developing TAF and dolutegravir, to work together, because we see those formulations as potentially a very good formulation for low and middle income countries, as they could be co-formulated in a single pill at a small dose, and also to bring that dosing and that pill down to the pediatric sizes, because we want to make sure that peds are not left behind.
I noticed that that's something that is becoming more and more important, even with the pharmaceutical companies, or maybe especially for the pharmaceutical companies, who have to develop the drugs. So, like, I spoke to John Pottage at Beav, and he says we will never bring a drug forward that can't be made a version of it, or a dosing size for the pediatric population.
Well, that's perfect. That's good to hear. It just sometimes takes more time than we would like to see. We'd like.
I mean, they want to do almost a concurrent evaluation and say, okay, can we formulate this? Is this something that will be a formulation that they can take, and or a delivery method that they can abide by?
Yeah, and I think that's exactly what we're going to need, because we have also made recommendations in our new guidelines about early infant diagnosis, and potentially bringing early infant diagnosis to birth. So in South Africa, you know, on the heels of the Mississippi baby evidence that perhaps treating early, and even some of the science that's coming out of CROI, that you could reduce the reservoir and change the immune system if you treat really early. So for infants, clearly it's a good time that if you could manage logistically to identify infection soon after birth with a mother who has HIV and then treat early, we may change the immune system and we may be able to reduce the reservoir for that infant and avoid infection.
Or at the very least, drop the viral set point so that the course of disease, the pathogenesis would be very different.
And so I think those are under study right now, but we did have enough evidence in our guideline process to recommend birth testing. And but we still lack some of the drugs for the 0 to 2 weeks age range, and so I think there's ongoing studies on how best to dose and to provide antiretrovirals at a very, very small age, a young age. And we're also doing quite a bit now on adolescents. We see that adolescents have difficulty with adherence. Adolescents are a growing group in sub-Saharan Africa and other countries, and they really do need a focus. And so in our new guidelines, we have a whole section on adolescent-friendly services. We've made recommendations specifically for the adolescent age range, age 10 to 19. And I think that's going to be a growing area where we're going to continue to need to put efforts.
These are those who've been infected from each other or from family, or
it could be vertically or horizontally, from the mom or from behaviors. And but still, I think they may be slightly different. Children who've been infected perinatally or from their mothers and grow, often by the time they reach the adolescent age range, are highly multi-resistant to various drugs. They may be fatigued with taking ARVs. They may have many issues in development, growth. And so it may be slightly different, but most of those children are, and as they grow into adulthood, are facing the same issues of all adolescents. And I think they need special care and special attention from WHO as an important group that we need to look out for, because mortality can be high as well as adherence and retention to programs can be low.
How do you develop programs that are, I mean, in our country we have at-risk populations for HIV and hepatitis and so forth. Is there, because in other countries, especially sub-Saharan Africa, they don't have the risk per se population. So how do you evaluate, or how do you test, or how do you plan to test people that are the whole population, I guess? Is that?
Well, I think that's a really good point, that, how do you maximize your HIV testing in a time where perhaps resources are flat and the risk of HIV is going to be higher in certain groups than others. And from the WHO, we call persons at higher risk key populations. So this might be persons who inject drugs, in prisons, sex workers, men who have sex with men, transgender persons. And in some countries, there's all sorts of vulnerable groups who seem to be at higher risk. In certain places in Africa, they may be working in mines, working in boats, in fisheries, or fisherfolk, or in trucks, etc. So I think that not only do we suggest that there should be provider-initiated HIV testing. So if somebody presents into a clinic or a hospital and looks like they could have HIV, have tuberculosis, they should get HIV testing.
Or has an STD.
Or an STD, all those sort of critical signs of other infections. But then again, it's also targeting certain populations who may be at higher risk, who haven't normally engaged in care. There's some really exciting programs in Uganda, Kenya, where they're doing sort of multi-disease campaign testing, or other places are doing home-to-home testing. And I think self-testing is going to be a really new avenue that will help persons who may not engage in the healthcare system to test at home and then get themselves, or through referral processes, get into clinics so that they can be retested and then engaged into care and start treatment if they're ready. And so more targeted testing of certain populations, multi-disease community testing where you can engage people around blood pressure testing or diabetes testing, and at the same time offer an HIV test.
What's good to hear, it seems as though you're looking forward at what the next, or the trend that's headed, and where is that trend headed, and we have to get ahead of the curve. So it seems like that's exciting to me to hear, because we were always playing catch up in the old days. we're barely dragging our butts around to where we have to be, much less now you're thinking. And of course, with the limited resources, it makes that difficult, but certainly admirable to see that planning in place.
Yeah, I think, WHO, UNAIDS, the rest of the UN system and the world has set these very ambitious targets. The 90% of people with HIV knowing their status, 90% of those on treatment, 90% of those with a suppressed viral load. And I think even in the United States, where I know best as well, we have a very difficult time getting there.
Yes.
And we're expecting
Yes.
this for the world. And surprisingly, or not surprisingly to me, I don't think, there are some countries that will make it. The Rwandas of the world. Botswana will have a presentation today showing how they're getting close to their 90-90-90 targets. I think it's an aspiration. There are some countries, though, that will need support to get there, and they have huge populations that need to be maintained for 20, 30, 40, 50 years or more of treatment. And so that's also the next phase of looking, what is a sustainable model? What is a chronic care model? Can this be a vertical program for the next 50 years, or does it need to be now integrated into what we call at WHO a universal health care approach or system? And that's what our health sector strategy for HIV outlines, sort of puts it in the context of eventually there will have to be a transition of moving the HIV program into a more, primary care, universal health care, but without losing the elements of quality and I think a lot of it is about scaling up viral load, scaling up the treatment access, and maintaining that by the country's own finances eventually.
Well, you have a number of years ago, it must have been 10 or 15 years ago, when we were in dire straits, a number of the presidents of the former countries, or former presidents of the countries in Africa, much like President Clinton did, became a champion of the cause and did some good things. Is that still going on? Because it seems like that's what we need is leadership.
There is great leadership in certain countries. I think, like everything with the switch from the MDGs to the SDGs, there's one health focus area in the Sustainable Development Goals. The focus is on many other problems as well, as you know, and so global warming, other issues, other health issues.
The world is sick.
Ebola, Zika, infections, health security, antimicrobial resistance. So I think HIV is not as paramount in leadership's minds, but it's good that we have UNAIDS and others who are out there advocating and pushing for the 90-90-90 targets, because it keeps it on the tongue. And it seems to me that if you go to many meetings of health ministers and finance ministers, they know what 90-90-90 means. They're looking to try to make those targets. So I think there is good leadership, but it needs to be sustained.
Yes.
Yeah.
Well, we can hope that you will be there to push and push and push.
I hope so. And it's a joint effort, isn't it?
Yes, it is. Well, thank you so much for being here, Meg.
Thank you.
I really appreciate your time.
Nice to be here.